Natural bioidentical progesterone versus synthetic progestins. The term progestin refers to a synthetically produced hormone that differs in structure from progesterone. In contrast to progesterone, which is only one molecule, there are numerous synthetic progestins used in hormone therapy. Research increasingly suggests that synthetic progestins do not necessarily act like natural progesterone within the same tissues because of various chemical structures. Progesterone levels decline during menopause, which can lead to symptoms such as hot flashes, night sweats, and vaginal dryness. Natural bioidentical progesterone, which is identical to the progesterone produced by the body, can be used to treat these symptoms. It can also be used for both the prevention and treatment of reproductive disorders such as endometriosis, uterine fibroids, and PMS. In contrast, artificial progestins, which are synthetic versions of progesterone, are contraindicated for use during pregnancy and can actually increase the risk of miscarriage. They can also cause a number of side effects, including weight gain, headaches, and depression. Therefore, natural bioidentical progesterone is the preferred choice for both the prevention and treatment of pregnancies, reproductive disorders, hormonal dysregulation in menopause, etc. Bioidentical progesterone and synthetic progestins are structurally dissimilar molecules that bind to and potentially activate the same receptors, but not in the same manner. They can have different agonist or antagonist effects on disparate physiological systems. For example, while synthetic progestins like medroxyprogesterone have been found to stimulate cancer growth, bioidentical progesterone has been shown to impede the growth of certain types of cancer. These differences are likely because bioidentical progesterone is metabolized differently by the body and has a more diverse range of target tissues. As such, it is important to consider the type of progestin when designing hormone therapy regimens. In general, natural bioidentical progesterone is preferable to synthetic progestins as it is associated with fewer side effects and health risks. More so, levels of progesterone and not medroxyprogesterone can be easily measured in the blood and saliva. Provera-TM is a synthetic form of progesterone with a wide range of effects. A majority of such effects are the exact opposite as compared to natural bioidentical progesterone. Progesterone is necessary for ovulation and menstruation, and it also helps to prepare the lining of the uterus for pregnancy. While Provera-TM does share some similarities with natural progesterone, there are also some important differences. Provera-TM has additional molecules that make it chemically different from the progesterone found in the female body. These changes were made so Provera-TM could be patented, unlike our natural hormones. Some women may choose to take Provera-TM as a way to treat certain menstrual disorders, but it's important to be aware that this is not the same as taking natural progesterone. When these synthetic progestins are used instead of natural hormones, women suffer from further hormonal imbalances and do not receive the desired health benefits. There is a growing body of evidence suggesting that estrogen and progesterone use may be associated with a lower risk of breast cancer in menopausal women. Observational studies have found that women who use hormone replacement therapy, HRT, containing these hormones have a significantly lower risk of developing breast cancer than those who use synthetic progestin-only HRT. There is confusion among experts about the synonyms for progesterone, such as progestin and progestogen. These are often used interchangeably, but they are not synonymous. Progesterone is a natural hormone that is produced by the ovaries. Progestin is a synthetic form of progesterone that is sometimes used in birth control pills and other hormone therapies. A progestogen is a general term that refers to any substance that mimics the effects of progesterone. Although all three of these terms are related, they are not interchangeable. When discussing hormone research, it is important to be clear about which term you are using. There is increasing evidence that synthetic progestins do not always act in the same way as progesterone in target tissues. This has long been understood with respect to the treatment of pregnancy and fertility issues when progesterone is effectively prescribed. Yet, synthetic progestins are contraindicated. The different chemical structures of synthetic progestins mean that they bind to different receptors and can have different effects on the body. As such, it is important to be aware of the potential differences between synthetic progestins and progesterone when considering treatment options. With more research, we may be able to better understand the mechanisms by which these two hormones work and develop more targeted treatments that can offer more consistent results. A large body of evidence suggests that synthetic progestins, which are often used in birth control pills and hormone replacement therapy, may increase the risk of breast cancer. These drugs work by mimicking the hormone progesterone, but they may react differently with progesterone receptors in the body. A significant consequence of the side effects seen with synthetic progestins has been an increase in the risk of developing breast cancer. Clinical trials, such as the Women's Health Initiative, in which more breast cancer was seen in the group taking synthetic progestins, did not study natural progesterone. Natural progesterone has been shown to be safe and effective in numerous studies, and it does not appear to increase the risk of breast cancer. In fact, some evidence suggests that natural progesterone may even help to protect against breast cancer. For example, one study found that women who used natural progesterone had a significantly lower risk of developing breast cancer than those who did not use the hormone. Given the dangers of synthetic progestins, it might be better to use natural progesterone instead. In a recent study, postmenopausal women were given either natural progesterone or medroxyprogesterone acetate, MPA, in addition to estrogen. The women then underwent exercise testing to evaluate myocardial ischemia. The results showed that natural progesterone enhanced the beneficial effect of estrogen on exercise-induced myocardial ischemia, while MPA did not. These findings suggest that natural progesterone may be a more effective treatment than MPA for exercise-induced myocardial ischemia in postmenopausal women. Estrogen is known to have protective effects on the heart, and this research suggests that natural progesterone may help to amplify those effects. This could have implications for the treatment of heart disease in postmenopausal women. One major difference between natural and synthetic progesterone is the frequency with which they must be taken. Natural progesterone must be taken every day in order to be effective, whereas synthetic progestins can be taken much less frequently. This is because natural progesterone is rapidly metabolized and eliminated from the body, whereas synthetic progestins are not. As a result, patients on natural progesterone need to be more diligent about taking their medication. But many people find that the benefits of natural progesterone are worth the trouble of having to take it more often.